Welcome to Evidence Mastery with Dr. Masood Tusi. I am going to help you understand what gallbladder and bile duct tumors are and how they are managed. Please note that this video is for education only and will not replace your doctor's advice.
All right, today we're going to dive into the world of gallbladder and bile duct tumors. Now, you might not hear about these as often as other cancers, but trust me, their impact is significant. So getting a really clear, evidence-based picture is just so important. And that's true whether you're a patient, a family member trying to understand, or even a fellow clinician.
Okay, so here's our game plan. First, we'll get a handle on what these cancers actually are. Then, we'll talk about the signs and symptoms to look out for. After that, we'll walk through how doctors diagnose them. And finally, we'll wrap up with an overview of treatment. Sound good? Let's get started.
All right, first up, understanding biliary cancers. Let's start at the beginning and really define what we're talking about here. You've got the gallbladder and this whole network of tubes called the bile ducts. They work together, but, the cancers that can pop up in them are actually pretty different.
So, the main cancer we see in the bile ducts has a bit of a mouthful of a name, cholangiocarcinoma. It's pretty rare. We're talking fewer than 3 people out of every 100,000. But here's the key thing you need to know. The evidence is clear that these tumors are almost always malignant. And what does that mean? It means they're not just benign growths. They have the real potential to spread.
One of the most important things with these cancers is where they're located. It's not one size fits all, and this chart really breaks it down for us. Look at this huge slice, about 65%. That's what we call peri-Hiller tumors, or sometimes Klatskin tumors. They pop up right at this supercritical spot where the bile ducts are leaving the liver. Then, you see the rest are divided between the distal ducts, that's further down the pipeline, and the ones that actually start inside the liver.
Okay, so that's bile duct cancer. But what about gallbladder cancer? Well, as you can probably guess, this one starts in the gallbladder itself. And even though they're right next to each other in the body, their stories are really different, especially when you look at the risk factors. For gallbladder cancer, the evidence is overwhelming. It's all about gallstones. I mean, they're found in up to 95% of cases. That's a massive link.
And this next part, well, it really shows us just how tough this disease is to fight. Gallbladder cancer is incredibly aggressive. A key study from Hundal and Schaffer back in 2014 found that the overall median survival was just 6 months. That number is just so stark, and it really drives home why we are pushing so hard for better ways to find it earlier and treat it more effectively.
Okay, let's move on to our second section, recognizing signs and symptoms. So, what does this actually look like for a patient? Knowing these clinical clues is absolutely the first step. It's what gets the ball rolling towards a diagnosis.
All right, so most of the symptoms, they really all come from one core problem, a blockage. The tumor literally blocks the bile ducts. And when that bile can't flow where it's supposed to, you get this classic set of 3 signs. First, there's painless jaundice. That's the yellowing of the skin and eyes. Then there's pruritus, which is a fancy word for intense full-body itching. That's from bile salts building up in the skin. And finally, you might see oxalic stools. Basically, pale or clay-colored stools. That happens because the bile isn't getting into the gut to give it that normal brown color.
Now, on top of those classic signs of blockage, there are also more general symptoms, what we call constitutional symptoms. And these can be tricky because they're pretty vague. We're talking about things like a dull ache in the abdomen, not feeling hungry, losing weight without trying, and just feeling wiped out all the time. Sometimes, though it's less common, a doctor might even be able to feel a mass in the belly during an exam.
Here's a really interesting clinical clue, especially for the medical professionals watching. It's called the Courvoisier sign. So what is it? It's when a patient is jaundiced, and you can actually feel their gallbladder. It's enlarged, but it doesn't hurt when you press on it. This is a huge clue that tells us the blockage is likely distal, meaning it's further down the bile duct system.
Right, so when all these signs point towards a possible problem, how do we actually figure out what's going on? That brings us to Section 3, the path to diagnosis. Think of the diagnostic process like a funnel. It starts broad and gets more and more specific. It all begins with that clinical suspicion based on the symptoms we just talked about. From there, the very first step is usually a simple, non-invasive abdominal ultrasound. If that shows something's not right, we move to much more detailed pictures, like an MRCP or a CT scan. But, and this is the most important part, the only way to be 100% sure it's cancer is that final step, getting a piece of tissue for a biopsy.
And I really want to double down on that point. The scans, the imaging, they can give us incredibly strong clues. They can make us almost certain.
But at the end of the day, seeing is not the same as knowing. The only way to get a definitive diagnosis is to look at the cells themselves under a microscope. That tissue sample is everything.
So let's just quickly run through the main tools in the diagnostic toolbox. We've got the ultrasound, which is almost always the starting point. Then we have the heavy hitters for imaging, MRCP, which is basically a specialized MRI of the bile ducts, and CT scans. Then there's ERCP, which is a procedure where we use a scope to go in, look directly at the ducts, and grab those all-important tissue samples. And finally, we can use blood tests to look for tumor markers like CA19-9. They're not a diagnosis on their own, but they can definitely add to the picture. So once we have that confirmed diagnosis, what's next? Well, that brings us to our final section, an overview of treatment. And I have to say, managing these cancers is really complex. There's no single recipe. It's all about tailoring the plan to the individual.
Really, the very first question we have to ask when making a treatment plan is, what is our goal? It's like a fork in the road. On one path, we have curative intent. This is for when the disease is localized and we think we have a real shot at removing it completely. On the other path, for more advanced cancer, our goal is palliative. That doesn't mean giving up. It means shifting the focus to relieving symptoms, managing pain, and making sure the patient's quality of life is as good as it can be.
And one of the most powerful tools in palliative care is something called stenting. It's a really elegant solution to that blockage problem we talked about. You can see it here. We place a tiny tube, a stent, inside the bile duct. It acts like a little scaffold, propping the duct open so bile can flow around the tumor. This simple procedure can make a world of difference, dramatically improving things like jaundice and itching. It's all about quality of life.
Now, when we're on that curative path, surgery is really the main event. It's our best shot at a cure. And as this table shows, the type of surgery and the outlook really depends on where that tumor is. If it's inside the liver, a partial liver resection can lead to a 5-year survival rate of 40 to 60%. For those tricky parahilar tumors, it's a bit lower, 30 to 50%. And for distal tumors, it often requires a very big operation called a Whipple procedure, with survival rate around 27%. These are major surgeries, but they offer the only real chance of a cure.
But surgery is rarely the whole story. We almost always build on it with other treatments. The evidence strongly suggests using chemotherapy after surgery, we call that adjuvant chemo, to help mop up any stray cancer cells. Sometimes we even give it before surgery to shrink the tumor and make the operation easier. For a very small select group, a liver transplant might even be on the table. And what's really exciting is the emergence of newer treatments like targeted immunotherapy, which is showing some real promise, especially for gallbladder cancer.
Okay, let's boil this all down to the key takeaways. First, these cancers are uncommon, but they are very serious. Second, that unexplained blockage of the bile ducts, that's your big red flag. Third, getting a diagnosis is a step-by-step process of imaging and, crucially, a biopsy. Fourth, treatment plans are always built around one of two goals: cure or palliation. And finally, for people with localized disease, surgery is the only path to a potential cure.
And all of this really leaves us with one huge, lingering question. We know these cancers often show up late in the game. So the real challenge for all of us, researchers, doctors, is this. How can we get better at finding them earlier? What's the next breakthrough in screening or blood test that will let us catch these diseases when we have the best chance to cure them? That's the problem we need to solve.
I hope you enjoyed this video. Please feel free to share your experience or questions in the comments. Please note that I won't answer personal questions. If you found this video helpful, don't forget to subscribe to my channel.